Better clinical conversations, better patient care. Learn practical skills anytime, anywhere. NaRCAD Skills Lab.
Welcome to NaRCAD Skills Lab. I'm Bevan Amira, the Deputy Director here at NaRCAD, the National Resource Center for Academic Detailing. And today's Skills Lab topic is all about patient focus groups. We're calling it Listening to Learn, using focus groups to strengthen academic detailing initiatives. And the whole goal of Skills Lab is that you'll learn skills in under an hour that you can start running off with and applying as soon as you're done listening. Glad to have you here with us today. The goals for today's session include understanding the importance of the patient voice and realizing that inviting that patient voice in through focus grouping can strengthen your academic detailing programming. We also want you to have a chance to explore practical strategies for planning, facilitating, and analyzing focus groups and their data. Last but not least, we'll review examples of the ways that focus group findings can be utilized to inform your detailing content. Let's talk about the case for the patient voice. Why do we want to hear about patient voices when in academic detailing, our goals are to go in and listen to the clinicians? A good academic detailer takes some of the best evidence-based medicine tools and resources and goes in a one-to-one format to meet with those clinicians, hear what they need, really understand their knowledge, behaviors, attitudes, challenges, and help them work through those to start trying new behaviors, trying to adopt new approaches to screening, treatment, prescribing. So why ask the patients what they need? Well, if we don't, then we don't know if we as detailers are hitting the mark. We can be going with what the best quantitative data says we should be doing, but if we don't ask the patients themselves what kind of care they need, we're leaving them out of the loop and designing care for patients without their input. Statistics only convey so much, and people are so much more than just numbers. Incorporating the patient voice can do wonders at counteracting misconceptions about entire groups of people. Yep, we're talking about stigma. When a group is stigmatized, let's say people who use substances, hearing from a patient about their experience can be really empowering, not just for the patient, but for providers and anyone who helps to care for them, as well as community members who may carry implicit biases. We know that patients are the experts on their own experiences, and that letting them speak, inviting them to speak, and honoring what they have to say upholds their dignity. And that's something we want to do as we're building academic detailing campaigns. It also ensures that we don't miss the mark when we're building tools and materials for clinicians. It really helps us educate clinicians about what patients are actually saying they need, besides what we think the data says they might need. So if you're not convinced yet, we're going to give you an example that might help. Here's a statistic. It's pretty compelling. Let's take a look. In 2022, 54.6 million people needed substance use treatment, but only 1 in every 4 of them received it. That's only 13 million. That leaves over 40 million people who did not get the care that they needed. Now, let's pretend I'm a detailer and I went in and conveyed this very information to a clinician. And then I said, how compelling is this to get you to change the way you provide linkage to care, to substance use treatment, or offer any sort of medication for opioid use disorder? I'm going to ask you listening to think about how compelling it is and rate it in your own mind, with 1 being not very compelling, 5 being somewhat compelling, and 10 being very compelling. And while this is a recording and I can't hear you say aloud or see what you wrote down as a number from 1 to 10, I can say that when we've done this live, most people have said, it's an impressive statistic, but I don't think it'll get clinicians to do anything differently. And here's why. It's a broad statistic, and it can be overwhelming for clinicians to hear, hey, did you know that over 40 million people didn't get care that they needed from the healthcare system? That doesn't make any clinician think, gee, I better change my behavior. I'm responsible for 40 million people. It also leaves the people themselves as just one of millions of bits of data. That's not what we want. Now let's look at a qualitative approach. Here are two quotes from folks with substance use disorders, and they've shared them through focus grouping. Here's the first. Hospitals treat us horribly. I've seen my friends risk their lives with bad infections because they don't want to go to the hospital. They'll just find something wrong with you so they can boot you. Here's the second one. I went to 5 rehabs last year, and now there's a note at the hospital that I don't have psych problems. It's drugs. So now I can't get help or be admitted. The best I ever felt was after being admitted to psych. I got stabilized, but now I can't get back there. These two quotes really tell you a story. Now, in your mind, rate how compelling you think these qualitative bits of data are in motivating a clinician to think differently and be open to change. Again, with 1 being not very, 5 being somewhat, and 10 being very. We found that people have often responded to this exercise thinking, hey, if I were a clinician and I received either a sound bite like this, saw a picture of somebody with this quote next to it, or watched a video of someone telling these stories, I would feel more compelled to try to make change and stand up for these folks. So that's the beauty. That's the beauty of qualitative data. Here's more about the power of qualitative data, why it's so compelling. Qualitative data is actually just as rigorous as quantitative data when it's collected accurately and analyzed systematically. And lots of times, it provides a more actionable space for tailoring, detailing interventions to specific populations of patients. Qualitative data can reveal context, emotions, lived experience that quantitative data just can't, especially when it comes to experiences of being met with stigma and barriers to care. You don't have the opportunity to learn about stigma as much when you can't talk to a person about the ways in which they've been stigmatized. Storytelling is powerful. It can help shift clinician behavior by humanizing the data, matching faces to statistics, which then deepens empathy. So now that we have a sense of why qualitative data is so powerful, how do we gather it? We do it through focus grouping. What's a focus group? You may have heard this many times over across your career, but here is the precise definition that the CDC offers. It's a qualitative data collection method where a facilitator interviews somewhere around 6 to 12 people who share similar demographics or characteristics that researchers want to study. A facilitator will guide a 60 to 90-minute group interview on average. The environment of that group, of that setting, needs to be one that encourages engagement and open sharing from participants, which means the facilitators or facilitator need to build an environment of trust, of transparency, and one where inclusivity isn't just okay, but is honored and celebrated, where different pathways to folks' lives and diversity are upheld, and where there's plenty of room for marginalized folks to speak about their experiences. So how do we get those participants recruited and ready to come to a focus group? Thinking about the who is critical. Look at your AD intervention planning materials. Maybe you've already made a detailing aid and you have your key messages ready to go. Which patient population does it benefit? Get specific. Think about age, geography, gender, socioeconomics, ethnicity, or race. Get as specific as you can. And then, once you've determined the characteristics of your desired participants, try to seek folks out who match those characteristics. You'll want to screen participants who apply to ensure they actually meet your desired criteria. Think about how many folks you want. The number of participants in your focus group can really change the depth to which you can go in terms of acquiring data. So, for instance, if you spend an hour with 12 people, you're going to have a harder time getting down to those next level questions, those next level experiences, and having time to follow up on what people share. But if you have 3 or 4 folks, you may be able to go more deeply. So think about what your costs are, what your budget looks like, how many people you want to speak to, and also how many people are available. While the CDC says 6 to 12 is typical, sometimes even just getting 2 or 3 folks to speak to you can really make a difference. Now, how do you find these folks? You'll want to recruit participants through either your own organization's connections. So if you're in a public health department, you can think about, what other programs do I know? Are there programs that directly serve patients? Can I speak to the leaders or organizers of those programs? Think also about clinics, community health centers, community gathering spaces. Sometimes even just coffee shops are a great place to go flyering. You can also think about social media. What kinds of simple ways to describe this experience and this opportunity can you create through marketing materials and then put on things like Facebook, X, and so on? You can also recruit people through professional networks or existing advisory structures. And when in doubt, ask leadership, ask colleagues you trust, ask people who work directly with patients. Next up, discussion guides. You'll want to plan what you want to discuss in a focus group in advance. You certainly don't want to wing it. A discussion guide acts as a roadmap for the facilitator or facilitators who are leading the group. It will outline the topics and the open-ended questions, and those questions should be clear and aligned with your objectives. They should give you information that aligns with the key messages you are seeking to deliver to the clinicians that the detailers will be meeting with once they're in the field. Here's some examples of good focus group questions. What do you think people get wrong about X? Let's say X is smoking. What do you think is most important for people to know about how smoking impacts the ways that people are treated by clinicians? What might be different if clinicians got direct feedback from patients about mental health challenges? Whatever the issue may be, the clinical topic and the focus of your intervention, weave that right into some of these examples. Figure out what it is you want to know, and then build your questions that way. Work backward. You don't have to use these examples. These are just to give you an idea of what kinds of open-ended questions could really help. Now let's talk about budget. We're going to talk about virtual versus in-person focus groups. Now, of course, you want to offer your participants some sort of incentive, whether that's a gift card or direct payment, whether it's a meal, something like that is critical. You certainly don't want to ask participants to participate for free. Patients are the experts on their lived experience, and they should be treated and compensated like any other expert. If you want to do this virtually, that helps with access across broader geographies. It doesn't offer you the opportunity to have a meal together or build community together. Virtual can be less expensive if you're not hosting a meal or going to be paying for a meeting space or venue. In-person has its own benefits and drawbacks as well. Think about what's right for you. And then make sure no matter what the setting is, you compensate those participants. You want to pay the market value, the same value that other experts in the field that you're studying would be paid. And think about that for a moment. If you would pay an expert on substance use disorder, the clinical expert, $50 an hour, you should be paying a focus group participant that as well. Don't just offer them a $5 Starbucks gift card. Offer them something substantive and take care of them, especially if they're meeting you in person. You should make sure there's plenty of space, a comfortable space for them to sit, as well as water or other beverages and food or at least snacks. Now you want to think about the budget that you should have for data processing and analysis. Who will you be paying, or is there a member of your team who can help with things like transcribing the content of the session, coding that content, and pulling out themes? That's all very important. You'll also want to think about, do you need to pay for a transcription tool? Do you need to pay for an expert in data analysis, qualitative data analysis? Plan all of these things up front. Here's a form, an example that you can use called a focus group consent form. You can find this online by typing in focus group consent form and finding plenty of examples on Google. You want to make sure that since you'll be dealing with human subjects, that you consider their needs. Ask your leadership in advance if there are specific guidelines at your institution or organization for working with human subjects. You want to make sure they know that they're going to be recorded, and they absolutely need to be, because you cannot rely on a person sitting in a focus group, no matter how fast they type, to be able to transcribe accurately everything that people are saying in real time. If you're meeting in an in-person space, we highly recommend that you use more than one recording device. Nowadays, we record a lot of things on our tablets or our cellular phones, but let's say you're recording on a cell phone and suddenly someone calls you, you're going to lose the recording, and you absolutely don't want to miss a chance to collect all of that golden data. So have a tablet or a laptop or two set up when you're recording, and make sure you get permission from everyone using a focus group consent form. Again, you can use an example like this by Googling focus group consent form example. All right, next up. Focus groups are fantastic, but they do have their limitations. Let's talk about what those are. First of all, generalizability is a big one. Findings from focus groups are often not representative of the larger population. If you only have 4 people sitting in a group, those are just 4 people. And while what they have to share is meaningful and important, it's not necessarily going to represent every patient. So be aware of that. If you need to host more than one focus group, that can help. Also consider the fact that group opinions are something that limit your ability to get accurate data. Some participants may go with the flow, nod a lot, and say, I agree with what she said, when there's a dominant speaker or two. They also may hesitate to share differing views, especially based on social dynamics. So consider that as well. And again, make sure anyone who is facilitating uses care to invite people who are more hesitant to speak up to have space and share the mic. The facilitator's tone and phrasing is equally important. So making sure it's open and that it's not leading questions that are being asked, so that there's no unintentional influencing of participants' responses in advance. Also, consider the fact of the bias of social desirability. Some people, when they're in a larger group, may give a response or an answer that seems socially acceptable rather than what they actually think, especially if the topic at hand is one that is highly stigmatized. In that instance, you can also consider having follow-up interviews with individuals to make sure what they really feel matches what they shared in the larger group. Another consideration and limitation is data complexity. Qualitative data from focus groups can be difficult and time-consuming to analyze in comparison to quantitative data. So again, make sure you plan ahead and build in plenty of time for the person who will be evaluating and analyzing the data to have enough time to code it and make sure that they are able to see themes and they're not rushing. And last but not least, we'd love you to consider the fact that there's limited depth. Focus groups might not allow for the deep exploration of individual perspectives based on the timing, and again, these other considerations such as social desirability bias and group opinions. So again, when there is an opportunity, time and money in your budget for you to have one-to-one interviews, that's a wonderful thing to tack on to this approach. All right, let's give another example here. We're going to talk about some data that was from a real detailing campaign. How do you use the data from a focus group? Here's an example. So there was a campaign about harm reduction for people who use drugs. On the left side of this box, we knew that there was a broad issue that people who use drugs often feel unheard and feel that they are treated unfairly. In the center here, we have an issue that was identified by focus group participants, and here's a quote that backs it up. Quote, "I'd be more comfortable if I had somebody who walked in my shoes, a doctor who knows what it's like to go through withdrawals and the cravings and to be able to help us get the exact treatment that we need. Just doctors treating me like a real person," end quote. On the right, we realized that there was a key message and an opportunity to identify opportunities to reduce potential harms using a patient-centered, trauma-informed approach. So what does this all mean? It means that putting a quote like this right into a detailing aid or relaying this quote to a clinician can really be impactful. It means that if there's permission, using a photograph of the participant who said this can be impactful. Sometimes it means that other detailing programs have taken video footage, if there has, of course, been consent and a consent signed form signed, to have this quote be used while someone is speaking in real time for that humanization, for that deepening of empathy, and for clinicians to say, wow, I never thought of it that way. There are plenty of examples on our website for you to take a look at that really, really take the time to show folks how to do this and do this right. We'll share a few in just a moment. I'm going to share an example of a fantastic campaign, an academic detailing campaign from some friends of ours who shared at our most recent academic detailing summit about how they incorporated the patient voice into their campaign. Our friends over at the Iowa Department of Health and Human Services recently delivered a presentation called "The Power of We: Elevating the Voices of People with Lived Experiences." Part of their campaign included interviews and focus grouping with patients. Here's a great quote from one video. "Professional people like doctors and lawyers and disability see my background, my history of drug abuse, and my history of living in the streets. They would see that and automatically wouldn't want to help me." This is an example of putting a face to a name, making somebody more than just a statistic or a number, and increasing the chance that a clinician will be able to deepen their empathy and connect to the material. Similarly, this campaign also looked at very specific patient voice data. Here's an example. They were working on an HIV stigma-related campaign. You'll see these following statistics were compelling. 66% of respondents said that they worked hard to keep their HIV a secret. 78% worried about people discriminating against them because of their HIV status. 33% of respondents experienced someone physically back away from them when they learned that they had HIV. And 27% said they waited to get tested because of the stigma associated with HIV. So again, having the patient voice is key, and including both a combination of qualitative and quantitative data, where the statistics incorporate things like lived experiences, stigma, feelings, fear. Those are very important and very compelling. Last but not least, this campaign also included ways that you can incorporate the patient voice beyond focus groups. So if focus groups are something that you're still thinking about whether or not you have the budget or ability to apply and try, check out some of these other ways that you can really ask people with lived experiences what they've experienced and what they need. So here's an example again from the Iowa Department of Health and Human Services presentation from the 2025 Academic Detailing Summit. It included incorporating people with lived experience through hiring, discussion, asking them to co-present and be part of trainings or outreach opportunities, using their quotes or short videos during detailing visits, including them on advisory boards, planning teams, community meetings, or group counseling sessions, asking them to look at provider key messages and detailing materials and offer their advice, perspective, and immediate reflections, and support them with paid roles as being advisors on detailing content. These are all ways you can incorporate folks beyond focus groups. But for focus groups alone, we want to say thank you for being with us today on the Skills Lab, for listening to learn, using focus groups to strengthen AD initiatives. Getting started is the first step. If you need help looking at perhaps a discussion document, figuring out what questions you're going to be asking, figuring out what consent forms to use, or you've just finished the Skills Lab and you still want to talk through your campaign with us, we'd be more than happy to help. Please email us at narcad@bmc.org. There's also the opportunity to explore our website for more examples of ways to incorporate patients in your detailing campaigns, especially in the aforementioned Summit series. We've had summits happen for the past 3 years, and there's archival information on the Summit series and Summit Hub pages, especially our inaugural summit, which focused on the patient experience. There are plenty of slide decks, recordings, and materials available there for you to peruse. If you're not sure where to start, again, please email us here at NaRCAD. We're so happy to help, and we really want to help you make sure that the patient voice is a part of your next campaign and every campaign moving forward. On top of that, we also have our webcast series, which includes webcasts such as the AD 101 episode, The Power of Clinical Outreach Education. So if you're trying to sell leadership on why this strategy is so powerful, this is the first thing that you should be sending their way. And if anybody on your team needs a refresher about academic detailing, why it works, and the beginning steps of how to implement it and how NaRCAD can help, again, we encourage you to go to our website, check out the webcast tab under the Learning tab. Thank you so much, and please let us know if you have any feedback or questions. You can use the QR code here, or you can reach out to us via email. We really hope you will reach out and ask us for coaching sessions, to hop on a call and talk about your next campaign, and to talk about anything from how to recruit the next grouping of detailers to get out into the field to how to build a compelling detailing aid. Here at NaRCAD, the National Resource Center for Academic Detailing, we are here to help you through every step of planning a successful quality improvement intervention, where changing clinician behavior is the center point, but where we're never forgetting the patient's needs. Thanks so much for being here. Take care.